So I want to welcome everyone to our Screenside Chat with CWD, and our guest today is Stephen Edelman, but here's where it gets a little tiny bit weird. Steve and I are having technical difficulties and we're unable to connect with one another. I've had to bring him up on my screen. Do you see his photo here? Very dapper. But Steve, your voice is here, isn't it?
Yes, it is. And
Thank God.
I was telling Carrie, I put on a nice dress shirt,
You
and
look
I'm
very nice.
I'm still wearing my pajamas, but I did take a shower, and but I'm happy to be here today and talk about a couple different topics.
Well, as with everything related to diabetes, it's all about being versatile and nimble. And when things don't go exactly according to plan, we have to find a workaround. So while we found a way to work around our pancreases, we're going to do it again with the audio and the video here. So I'm glad we can hear your voice. That is really important. We can see some pixelated version of your face here on my desk, but thanks for joining us. And you'll have to do a lot of the talking so it seriously doesn't look like me pretending to know you on my iPad. Okay.
Carrie, the contrast is so high, I look white.
You look a bit pale. Oh, how's that?
There's good. It's good. It's good.
Okay. So I'm going to find a way to get your mouth to move on this, but let's just, by way of quick introduction, Steve, could you just introduce yourself to the CWD community who doesn't know you and doesn't know you past this pixelated picture?
Okay. Yes. My name is Steve Edelman. I got type 1 when I was 15. I wanted to become a diabetes specialist, and to make a long story short, I didn't think enough information was going directly to the people living with the condition. So that's when I started taking control of your diabetes. Both Jeff and Carrie have been involved through the last 25 years. And so we pretty much promote patient education to adults with type 1. And I also work at the University of California, San Diego, and the VA. So I wear a bunch of different hats, but talking with patients, my brethren, I should say my fellow peers with type 1, that's sort of my true love.
And so you've kind of alluded to the fact that you are one of us as well as taking care of us. So could you tell us a little bit about your diagnosis?
Yeah. Oh gosh. I I was living in the San Fernando Valley. I was peeing. I was thirsty. I lost a ton of weight, and I kind of liked that because I was kind of a chubby kid. In fact, my nickname in middle school was the Stump, and I lost all this weight. I was fit into my sister's jeans. I was all happy, but I was just so tired and slept all day. My teachers reprimanded me because I had to go to the bathroom so many times during class. And then I finally got diagnosed. They threw me in the intensive care unit. Never heard of the word diabetes, and that was it. 19 diagnosed in 1970, June, in fact. This is actually my 50-year anniversary month, but you know what? I don't really celebrate that. I know other people do, and I respect that. I'm not a celebrating kind of person for that. Don't ask me why.
This is your 50th year with type 1?
Yeah.
Holy cow. I didn't know this was the year. I knew it was coming, but I didn't realize this was it. That's amazing. And I mean, you and I have done a lot of TCOID conferences together. So I feel like I've gotten to know you over the last couple of years, and I was kind of waiting for this so we could like medal you and stuff. No? Are you going to get the medal?
Do you know what, Carrie? For some reason, maybe I have to get on the couch or something, but I don't. It's not a milestone for me. I'm happy I'm here. I can still walk and breathe and see, and so I do admire other people that really get into that. I have no problems with that. It's just not me. I don't know why.
Well,
but I'm happy about living this long with diabetes. Yes.
Well, we are very lucky to have you as part of this community. And so kind of getting right into it, because part of what we wanted to talk about on this particular web chat was things like COVID-19 and telemedicine and diabetes devices. And that was like the niche of what we were going to be getting into, just so to address the elephant in the room that is not the technology problem we're dealing with right now. So people are really concerned about COVID, and it's a scary time, and there's a lot of anxiety and a lot of concerns and a lot of misinformation out there. So just to sort of jump right in, are people with diabetes more vulnerable to COVID or to poor outcomes as a result of COVID from your vantage point?
Yeah, that's such a great question, because everyone watches, television, and that first thing the newscasters say is, if you have diabetes, you're higher at risk. Well, you can't just say that as a blanket statement. Type 1 diabetes is quite different than type 2. And if you're someone with type 1 and your control is good, let's say your A1C is less than 8, then your chances of getting COVID and surviving are really no different than anybody your age. Now, let me just say, let's say your A1C is high, 9%, 10%. We know that it affects the immune system, the ability to fight off foreign bodies and viruses, infections, then you might be more prone to getting the infection just because you're more, just like you would get a step on a cut. Someone with good control, it would heal by itself. Someone without good control, it'll get out of control. You might need to have, I don't know, steri strips or some type of minor surgery. So basically, now that's just one bucket. And we know that, in this country, if you look at the data, the most people with type 1 have an A1C above 7. Now that's, like I said, no one really knows the cutoff, but they know the immune system really starts to not function totally normally when the A1C gets above 8 or the average blood sugar is around 200. Now, if you have type 2, I think by nature, except for the rare exception, you're going to be more at risk. Maybe not for getting it unless your control is really bad, but for surviving, because or I shouldn't say surviving, but having a prolonged hospital stay, because most type 2s have weight problems. That's inherently part of the condition. We know that being overweight puts you at risk for complications. And many people with type 2 have heart disease, kidney disease, underlying conditions, and they're older in general. So look at myself, I'm 64, and my control is pretty good thanks to looping and tandem control IQ now. And I think my risk is the same as any 64-year-old person. Look at those pecs. Oh my God. But once again, age is also a risk factor as well. So you can't really just say a blanket statement. Let's say for a lot of CWD folks, you're younger, you're healthier, you don't have a bunch of other medical conditions. If your A1C is less than 8, and I think your risk is no different than anybody else, if that makes you feel any better. If your A1C is higher, then now's a good time to really work to get it under control.
Mm-hmm. And I mean, I think there's a lot of news that is difficult to sift through, right? And people see a lot of potentially sensationalized headlines, and it's hard to get down to the nuggets of truth that are in there. So thank you for highlighting that really explicitly. So when we're talking about COVID and people dealing with it if they get it, or in efforts to avoid it, like how can a person with diabetes help to best protect themselves during these crazy times?
Yeah, you know what, I think when you look at the things we need to do to stay safe, it's really no different than the general population, and with a few minor exceptions. I think that obviously social distancing, quarantine if you're in that area, don't touch your face whatever you do, because it's the eyes, nose, and mouth. And that's why I think wearing a mask not only protects others if you're infected, but you protect yourself actually. And wearing big glasses like yours, that was not that's a and you wear a mask, you're covering your nostrils, your mouth. If you don't wear glasses, you could wear fake glasses, or something like that. But so just the usual stuff. But I'd say if you have diabetes, obviously we talked about getting your glucose levels under control. I personally think that keeping your glucose fluctuations as minimal as possible, the time and range thing, that's also very helpful. And also, I think the other thing to know, Carrie, is that people with type 1, if you do get sick, let's say not even COVID, let's say a regular flu, or, you just got to be really knowledgeable about sick day rules and how to treat those early at home to avoid going into ketoacidosis. And that we should know that anyway, but just be a little extra vigilant. And, eating right, exercise, and sleep. There's no magic to it,
Okay, so the basics, the health basics. And I know when people talk about making sure that your stress levels are lowered, it gets difficult to do that when everyone's baseline stress level has been ratcheted up a bit. But the health tenets of sleep and in eating well, that's obviously very important. And then there's also the mental health component of living through the pandemic as people with diabetes. So how can people with diabetes be taking best care of their mental health?
Yeah, I was just
Such an
talking.
easy question, right?
I was just talking to Bill Polanski. He's coming over later today for a walk in my neighborhood where we stay 6 feet apart, and that's part of my answer. Is I'm not a clinical psychologist, but I do think that talking to people, connecting with friends, Zoom, on the phone. So I have made it a point to reach out to friends that normally I wouldn't see very often if this whole COVID wasn't happening, because you only see them when you actually get into their physical space. But a lot of Zoom meetings, virtual happy hours, taking walks with people, just getting on the phone. So I think talking to others, your loved ones, friends, go through your address book. Now it's electronic. I still have my old one, and just say, oh my God, I haven't talked to John in so long. You just give a call or you send an email. And I think human interaction is key, because I think, people who are at home in quarantine, they may not have that much interaction. What do you think? I mean, you probably have some good things to add to that.
I know it's challenging to get that person-to-person contact while you're also considering the risks of having closer contact with people outside of your family unit. I mean, my husband and I live here with our 2 kids, and generally that's who we're seeing. So sometimes just the stress of bringing more people into our bubble or taking those risks, like it's a matter of threading the needle on what's the worst outcome, potentially being 8 feet away from someone who has the virus, or being completely isolated and having my mental health deteriorate. So I think we kind of walk that walk all the time. But the Zoom meetings, I'm for most of the time. Sometimes I find it a little stressful to be sitting. Like right now, this is unusual for me because we're like so close, but you're not quite there. So we'll definitely be turning this into a podcast instead of a video release.
Could everyone see you?
Yeah, that's all they can see. Just me and
And my
the
picture.
glowing you.
It's
So
not bad. Well, I agree with you. Zoom meetings can get old, but if you have friends, where I've done some for you folks under 21, I've had virtual happy hours. You can drink whatever you want, but it just and you do it for like an hour. It's really quite nice. But what you made a good point. You're at home with your husband, your 2 kids. You have a lot of interaction. You're busy. You're doing schooling. And other people are home alone, so you have to do whatever's best for you, what makes you feel good. And yeah, I think the emotional part is important. And you would agree too that everybody's anxiety and fear is different.
right.
Mine, I'm kind of in the middle.
Mm-hmm.
I'm cautious, but I went out to a restaurant in San Diego that has all the precautions. Bill Polanski, my good buddy, he's scared to death to leave his house. I finally talked him into coming over, go for a walk today, and he was wearing he was wearing his mask when we were walking. And actually, the street where I live, the streets are so wide you can easily walk 6 feet apart. And plus, being outside is a very safe place. But whatever level of comfort he needs, I'll put a bag over his head, whatever makes him feel better.
Well, that's the thing though, just acknowledging that there's a mental health
Yeah.
component to the living well with any of this stuff is a huge first step. So I'm glad you dragged Bill out of his house. That sounds like it's going to be really good for him. But also in terms of like dragging people out of their houses or not dragging out. So to transition a tiny bit to telemedicine, because COVID has made it so that people are not readily going in person to their appointments. And you had mentioned that this was like a big thing that you were seeing and happy to talk about. So how have you seen people with diabetes take advantage of the telemedicine offerings, and how can they make the most of those virtual appointments?
Yeah, I've spoken a lot about that. And on our TCOID website, I did a little program with Jeremy Pettis, who also has type 1, who's a diabetes doc like myself. And the whole purpose of the little program was to let people with diabetes know how to prepare for their visit. So I'm at UCSD in San Diego. I'm at the VA. All of our visits are televisits now, 100%.
Wow. How long did it take to get to that 100%? Was it immediate or?
Like immediate.
Oh, really?
Pretty immediate, because they just called everybody and said, due to the safety concerns, and people were very happy about that. Who wants to drive to the hospital park, have to wear a mask, and the VA and university, they screen people as they go in, which is fine, but it takes more time. Yeah, and I don't think there's any better condition than diabetes to do telehealth, to be honest. Most of the time, we don't really need to put our hands on you. It's mostly talking. That's why we're so poor. We don't have any procedures. I drive a used Tesla. No, I'm kidding. And so what we say in this video is this. This is actually a really good opportunity to get some quality time with your caregiver. Be prepared. So the first one is get your information together. You can take your own vitals at home, weigh yourself, get your temperature, take your blood pressure. You know, because you can do all that at home. The second is gather your data. You know, if you're on a CGM, our offices have a way to send that in, so it goes into the electronic medical records. But any way you can communicate with your doctor, every system's a little different. Even if you have to hold it up, I'm talking as if you guys are looking at me. I'm moving my hands.
They are looking at you, Steve.
You know, when I was shaking my head when you were talking, I'm looking at the picture. I'm going, hey, my head's not moving.
No, sorry.
Yeah, even if you have to like read off the time and range, the average blood sugar, or hold up, you know, the 24-hour graph, be prepared. And then, you know, you want to have a list of your questions. You know, nothing drives a doctor worse than someone says, I only have 10 questions. Like, oh my God, if you guys can only see our eyes roll around. You know, pick the 2 or 3 most important ones, and make sure you let the caregiver know. Say, hey, Dr. Edelman or Steve, whatever, say, hey, listen, I have a few questions. Let me know when you want me to ask them. Make sure you have all the prescriptions you need to be filled, you know, and lastly, you know, ask for a follow-up plan. Like, when are you going to meet again? And make sure that if you have any questions about the suggestions that that you were just given, make sure you ask. And you can do a lot, Carrie. In mine are 30 minutes.
Your telemedicine visits? Okay.
Yeah, and that's you know, most other caregivers 15, 20 minutes. But you know, you know, I think the schmoozing part's important, and to ask how you're doing mentally, emotionally with the whole thing, and you know, and everyone's really happy to talk about it. Just say, yeah, I'm doing okay, I'm not doing okay, and then you can go from there. But the main issue is be prepared for your telemedicine visit. I'll tell you what, Carrie, they sent out a little email, the university, and they're losing tons of money because you can't bill as much. Now, I don't really care because I'm on a salary, and it's relatively small, and they even threatened to cut people's salaries because the university, you know, they're losing tons of money. And they offered, if once we start going back, which is June, I'm going to do half my visits televisit and the other half in person.
Wow, so you guys start seeing patients in office in June.
Yep. San Diego's in good shape.
Go ahead. Yeah.
I was just San Diego's. We have had a total of 260 people pass away, 260 too many, and only 3% of people tested.
I think I lost you there for a second, Steve. Want to try that again? Oh my God, you're fading out and you're just.
Sorry, it looks like my internet may be fuzzing. Can you hear me now? Hold on. Hold on. Can you hear me now? I'm gonna.
See me.
Okay.
Hello?
Can you hear me?
Hey, did you lose me or did I lose you?
I don't know, but I lifted my laptop and I'm in a different room, so maybe that's it. I was just
doing great.
San Diego is doing extremely well, and we never really had a peak, to be honest with you. And you know that number called R naught, first one for every one person that has it, you could spread it to one person. And the goal is to have that number less than 1, and we are less than 1, meaning that the number of people coming down with it goes down and down. So yeah, San Diego, you know, Governor Newsom, we were the first state to do the quarantine, and thank goodness, because now we're finally opening up the beaches that you can actually sit down on. So I'll make a long story short, it depends where you live. And yes, they're going to start doing face-to-face visits in June.
Well, and you're saying you're doing half and half. So that'll be good because it'll let people ease into things. But whether it's a virtual appointment or a face-to-face appointment, people should be preparing for those either way. So the tips that you gave for preparation are applicable whether it's virtual or in your actual office, right?
It's a good point, because you'd be surprised how many people come in not ready to have a good visit. So this kind of, just like these type of virtual meetings and the Friends for Life meeting, there's a silver lining in the whole thing as well. And what was the other thing that you were going to ask me? Yeah, like, you know, it's funny when you do a virtual meeting at home, you see some really funny things. You see kids running around, the cat meowing. You can see a little bit of their home environment. People are wearing the craziest clothes, and I'll stop there. And then so you know what? It's kind of nice because you can see people in their own setting.
Yeah, you see them in like context of their existence, and that must be interesting. And you're saying you hear the cats meowing. My worst fear is having any cat walk through, and they always want to put their whole body in front of the camera, and that's and so does my son. So those are also unusual moments. But so have you had, like, is it weird to transition as from an in-person clinician to a virtual clinician? Do you find that you have to change your style and the way that you're communicating with people?
Yeah, I have to put on pants.
Not now.
'Cause
You don't even have to put on anything. I
no,
mean, right, you are just a virtual Steve. So
I'm gonna wear my pajamas the first day back at work. I swear. I keep threatening people. It's gonna be so funny. I'll wear a sports shirt. I mean, a dress shirt and pajamas. I don't think there's a big transition, to be honest. I The only reason I'm doing virtual is not to have a transition. I like it.
Mhm.
I'm going to
And I find,
continue. Yeah.
oh, I was going to say that I know a lot of people that live in city areas have access to clinicians without having to drive a really long way. But for people who are in more rural areas and are already driving 2 or 3 hours to see their endocrinologist, this must open up a lot of access points for them, just being able to use telemedicine.
You know, Carrie, from one of our Facebook Lives I did with TCOID, I said something like, we were talking about television. I said, well, now I can see anybody as long as you
Mhm.
call UCSD, get your. And the other day I saw someone from Ohio.
Mhm. Oh, really?
Yeah, you know, you don't have to see them now. Have you had a televisit
I
since this
have.
whole thing started?
But it hasn't been a telemedicine like through video. Actually, that's a question I wanted to ask you. Are you doing video chats with your patients, or is it all
It's
telephone?
all video, all video.
All video. Okay, so my telemedicine appointment was over the phone, which I found ineffective, but also I didn't have any big concerns that I was trying to address. So it scratched the itch that needed to be done, which were basically prescriptions and check-ins. But for like a person-to-person sort of contact, video makes it a lot easier, in my opinion, for patients to be honest and vulnerable about the things that they're really concerned about. I wouldn't in an email I'd be less likely to say, "Oh, I'm struggling with this," and over the phone I can hide behind the inability to see your face. But in video, you kind of can't hide how you're feeling. You
Yeah, you
can
were.
right now because you're not on video, but my
Oh,
awkwardness is on full display right now.
you know what? You look very good.
I'm trying not to panic.
No, you look good. And I think you're right. Face to face is important.
Mhm.
So, I mean, whether in the video is not bad. Now, you know, I'll never see a video person for the first time, like except for this guy in Ohio, or maybe other people that can't travel. But
Mhm.
I do think there's something that is irreplaceable, just like Friends for Life and TCOID conferences.
Mhm.
I mean, Jeff is doing a great job, really great job putting on a virtual conference. I was just looking at the website last night, and it's a challenge to do that. Yeah, you can tape a lecture and stick it on, but it's got to be more than that. So
Right.
I'm looking forward to opening back up again, and you're going to be our keynote speaker of our Omaha conference on August 1st.
On
But
August 1st.
we moved the date, and it was supposed to be August 1st,
Mhm.
and well, it's all virtual, so you don't have to worry.
No worries. I'll make sure my video works, I swear. But
Well,
yeah,
I'm gonna.
moving conferences like Friends for Life to a virtual, having the legacy of having had the conferences for the last 20 years, at least a lot of people know the general vibe and feeling. And so hopefully they can draft off of past experiences too while they experience the
Yeah,
virtual version of it. Do you feel the same way about moving some of your
yeah,
events to
yeah,
virtual?
yeah.
And that's,
Now we,
yeah.
we we do conferences in new cities too, so
Mhm.
we don't have that drafting going on. But yeah, we're gonna do our best to make it fun and interactive. And it's a 1 day conference, but as you know, we have that 3 day weekend for the one conference in San Diego that you've been
Mhm.
at 3 years in a row, and
Mhm.
trying to make that's a little bit more like Friends for Life because it's multi-day.
Right. And there's just an inherent challenge to making sure you bring the education and the connection for people and try
Yeah,
to do it through the computer. And that connection part can be a little tricky, especially when the video doesn't work. But kind of could transition just a little tiny bit more towards your personal diabetes stuff, because you've come at this from the clinician angle very strongly, and I'm really appreciative of the stuff that you've shared with us so far. But like your own personal diagnosis, you're clocking 50 years next month. with type 1. And I'm sure over the course of your diabetes life that you have seen technology evolve in a way that, I mean, I've only had type 1 for 33 years, that I want to like learn what it was like back, when you were first diagnosed. Like what was it like then, and how have things progressed towards awesomeness, like you said, control IQ and looping?
Carrie, you really are a good moderator. The way you bridged into that was like perfect. It's I know you don't think about it. You're so good at it.
Thank you, Steve. I really appreciate virtually you telling me this. This is so
You know,
weird.
whenever I start talking about how it was in the old days, like Jeremy starts pretending like he's playing a violin, and he
Hmm.
goes, "Yeah, you had needles made out of bamboo," and he starts going wah wah. So I'm
Yeah.
glad you asked.
Well,
Well,
I was also about to say when you had to walk uphill both ways to go to the endocrinologist's office. So I'm not absent the bad jokes, but yeah, I mean, when we look at what we have access to now, like it has gotten really wild just in the last 5 years.
yeah, people are really spoiled. Oh my God. I mean, without boring the younger crowd, when 1970 they didn't have all they had was urine testing. They didn't even have the
Hmm.
glucose meters that
Right.
we hit and prick our finger. They didn't have that. They didn't have the A1C test, and they had really old insulins. And basically, you took one shot a day of
Hmm.
NPH and regular, and you tested your urine, which was really not accurate. And
Right.
so the care was really archaic back then. And man, home glucose monitors revolutionized things. Oh
Hmm.
my
Was
God.
that like the first big thing?
Yeah, that was the first
Okay.
big thing. And then I would say that was in 1980. Then I
Hmm.
think the next big thing was the fast acting analogs. I think
Hmm.
Humalog was the very first one, and then followed by Novolog and Apidra. And then Lantus in 2000, because that's such a better basal than NPH, which is shorter acting. And then pumps came into play in the mid 80s, and they were important, but they just delivered insulin. There was nothing special that they did. And of course, then came CGM,
Hmm.
and we've evolved from really inaccurate ones to extremely accurate ones. I think so. Now we have the Dexcom G6,
Hmm.
we have the implantable Eversense, and then we have Medtronic, and then Libre. So
Right.
now we got four, and so I think most people should know about those. It's a rare type 1 that would not benefit greatly. If you're one of those type 1s that say I don't need it, I think you're full of it. Since you can't see me flipping you the middle finger, that's good.
Oh, Steve.
Now oh yeah, I just told you. But I think the most exciting thing is
Oh no.
that really is these hybrid closed loops.
Okay.
And I think, this is when the pump communicates with the CGM, and regulates your pump, and
Hmm.
it regulates your basal rate. So if your blood sugar is shooting up, it'll give you more than your set basal rate,
Hmm.
and opposite on the way down. It'll turn off if it predicts you're going to get low. And with the tandem control IQ, which is uh, has a little extra feature of giving you a correction bolus every hour
Hmm.
if you need it, small, subtracting time and range. And so we've gone from no communication at all, and the person with diabetes has to screw up their own control because they
Hmm.
don't usually, including myself, to changes in the basal rate based on your, continuous glucose monitor, the rate of change, your glucose in 30 minutes, to micro boluses every hour. And that's called a hybrid closed loop system. So Medtronic came out with the first one a couple years ago.
Hmm.
The system, with their sensor is not as user friendly. Some people are successful on it. The G6 plus the tandem has really been awesome. And then there's a lot of people using the looping. So for some of your viewers, looping is a non-FDA approved method where you buy a Riley link, a little tiny white thing. Too bad. Do you have one in front of you?
I don't, but we have a page on the CWD website under medical devices and treatment, and it links out to the DIY system. So
Yeah,
we can put a link in the.
yeah. Well, people can look it up,
Mhm.
and basically you can have a similar hybrid system with an old Medtronic pump or a Omnipod, not the one
Mhm.
that works with Dash, but the older one. And there are differences, and we have a couple really nice pieces on our website as well. And
Mhm.
I can't get into the details too much, but I can tell you, Carrie, I've had the most boring clinics that you have ever seen. Like I have a shared medical appointment where I have 8 to 10 people come in at once. I can
Hmm.
do it online through Zoom now, and you put up everyone's CGM, and they're all males with type 1 or all females with type 1. And we go around the room, we look at their Dexcom download, um, and it is shocking that almost every single person has an A1C less than 7 with minimal hypoglycemia. And for those of you that are familiar with time in range, 80% plus. And there's literally very few things I need to do other than, hey, what's your favorite movie that you've seen lately?
So,
I'm serious.
well, do you find yourself when you're working with your patients as a clinician, but also a person with type 1, do you find yourself sharing your own personal stories about what it's like to actually live with type 1 as well as treat people with it? Like, do you let them into that side of your existence?
I'd say most of the time, yes.
Yeah.
Yeah, I
So
mean,
why do you, because I know some clinicians choose not to do that when they have type 1, but tell me why you do.
well, you know what? I mean, everyone's different,
Hmm.
but I feel like every patient is more like a peer. We're
Hmm.
both living with type 1. I might have a little more knowledge. They might have something to teach me as well, which is not
Hmm.
uncommon, little tricks of the trade. And we're all trying to keep our blood sugars from spiking up and getting low, 24/7. So it's probably just a personality thing. I bond with my patients. All of them have my cell phone, my email. Why put patients through the hassle of having to page or go and through an office system to get a hold of me? And I have very few patients that abuse that. You
Hmm.
know, they, like very few. So, if someone's really needs a prescription quickly, they're going out of town, it's just better to text me or call me. And so I don't know. It's just a personality thing. I have doctor friends who have type 1 who do not like to share that. So it's
Yeah.
just like anything else. It's just a personal preference.
My endo, I know we've talked about this before, but my endo also has type 1, and sometimes we compare tiny war stories when we're there in the office. And it does help me feel like I can really say the stuff that's bugging me because I know he walks the walk and really gets it. And there's a nice camaraderie to that, especially as adults versus if I were a child comparing myself to an adult. But adult to adult, that pure connection is really helpful for me. So glad you're telling your patients that you have type 1.
Yeah. Oh, they usually find me. So
Okay.
yeah, we compare notes all the time.
Hmm.
And I'll be tough with people, like especially ones that have bad control and they don't want to wear a CGM. I said, are you effing kidding me? And
Hmm.
then eventually, when they finally get one, they say to me, how come you didn't tell me about this earlier? I want to strangle them. Uh, and and I really had to slap people around the last couple of months because I said, listen, John or Mary, you need to get a hybrid closed loop system. Here's your choice because you cannot do it on your own. I've been following you for years. You got a pump and a CGM, but your time and range just sucks.
Hmm.
And every single time they get it, they are so amazed how well they're doing.
Hmm.
And I'll tell you what, remember that video Jeremy Pettis and I did years ago about type 1 in 2026? The
Yep.
scene opens up. We're working at Starbucks because we lost our jobs at the
Hmm.
university. They didn't need us anymore because of, we called Ed Damiano a bastard, that son of a bitch, for developing the bionic pancreas because we lost our jobs because of him. I noticed
Hmm.
he's speaking at CWD as well.
Hmm. Yeah, he does a great update on Islet for the folks who attend Friends for Life, and it's amazing because they feel like they're on that journey, and I feel like I'm on that journey with Ed, and like excited for him, but also the fact that he speaks directly to us as his peers and not, you know what I mean? Like there's something really amazing about seeing behind the scenes on the research and getting all that information as it's happening. So having
Yeah,
clinicians and experts who come to conferences and just put it all out there and let people ask their questions, like there's power to that interaction. And I really love that he does that. Just like I'm appreciative that you're coming on here too. The only problem is people can't see your face, right? So they can't, you sound violent, like you're beating up your patients. You're not. I know you're not. It's more I know you have that frank back
I
and forth
am.
with them. And I'm sure like I know, but I know people appreciate that too because you're very real with people. And I would imagine if I were one of your patients that I'd respect that lack of throat clearing. Like you're not going to dance around a topic. You're going to get right to it. And I think that that's an appreciated approach.
Yeah, I mean, obviously you have to know your audience.
Hmm.
So, a 70-year-old type 1 is different than 25-year-old, and I mean, obviously they know I'm trying to help them, and so
Hmm.
it's a good, you got to develop a relationship first. Well, I'll tell you what, when I'd love to fix this camera problem one of these days, and then I can come back later on, and I'm giving one of the lectures at CWD, so you'll see my face then too. But it is helpful to see you at least, uh, because I mean, I see your expressions, and I appreciate that. And people are
Well,
learning all the cussing I do on today's show too.
as long as it's not me doing it, we're good to go. I'm trying to pretend to be a dignified princess. My children are right outside the door. They can hear me, so I have to really watch my mouth. But you were talking about, I know from your lectures and being at a lot of TCOED conferences that you are a big proponent of CGM. I've heard you talk about it, and basically you're like a big fan, and I see how it works for your patient base. That's what's come already. So is that the most important advancement in the last 5 or 10 years from your perspective?
No question. No
So what
question.
do you, oh, sorry, go ahead.
No, no, yeah, you go ahead.
Well, what I was going to say was if that's the past, what do you think is going to be the most exciting thing to come out in the next 2 to 3 years? Because I know there's so much stuff in the pipeline. And what are you
Well,
looking forward to as a patient, and what are you looking forward to as a clinician?
yeah, well, I think as a patient, well, first of all, I've talked about hybrid closed loop, and you've been on them as well. It's not it takes work. You have to learn
Mm-hmm.
how to use the system. You still have your ups and downs. So it's really a big step forward, but we still have ways to go. Obviously, the fully closed loop, high closed loop, like Ed Damiano's working on, and others,
Mm-hmm.
Tandem working on that. All of the hybrid closed loop companies, including Medtronic, Insulet, even the looping folks, are the holy grail is getting to the point where you could just plug in your weight, or the system gets to know you, and that's it. You're done,
Mm-hmm.
Carrie. All you got to do is make sure your pump is full and your
Mm-hmm.
CGM is going, and you could eat anything you want. You could eat more, you can eat less, you can eat different compositions, you could exercise, you don't have to exercise, and
Mm-hmm.
your blood sugar stays in a tight range. Think about that. I mean,
It it blows my mind. But you know, as you're saying that, I keep thinking it took me a little bit of time to accept an automated anything. So it took me some time to trust the CGM after years of not having one. Took me some time to trust the pump after years of not having one. So I always wonder, like, what would be the emotional learning curve for technology that truly is set it and forget it?
yeah, you know what? I mean, listen, I've been dealing with it for 50 years, and
Hmm.
I spend so much of my day thinking about adjusting, looking at my CGM.
Hmm.
I mean, I'm not sure what I'm going to do. I'll be looking at it no matter what. I'll still be counting carbs and saying, oh, yeah, I don't have to do that. But I do think, think about someone that's just diagnosed.
Hmm.
They, they get hooked onto one of these systems. They're, assuming they're super reliable, everyone has a backup system. I think when you look at the average A1C in this country right now, only about a quarter of people have a A1C less than 7. Why?
Hmm.
Because type 1 is tough. So I
Hmm.
think, I mean, my clinic, I'm not better than any other doctor. I might just get people on that technology faster. That's maybe what I should get credit for. And the average A1C in these folks is not only low, but there's low without hypoglycemia. I
Hmm.
think, Carrie, we obviously have 2 new emergency glucagon
Yep.
kit systems. That's awesome, but with these new systems, those situations where you're going to need it is going to be less and less. Mini
Hmm.
dose glucagon, I think, is going to be a really nice addition,
Yeah.
where instead of eating everything in the kitchen sink, you gain weight, didn't taste that good anyway because you're sweating. To give yourself a little pull out a glucagon pen and dial in a dose to bring you up without the rebound. I think that's quite nice. And think about it. If you can get a closed loop system, that really bridges the gap until there's a cure. Now,
Hmm.
I'm doing some work with a company called Prevention Bio. They're the ones that bought the rights to tablizumab, which is I don't want to get too scientific, but it's
No, go for it.
the monoclonal antibody that was published in New England Journal of Medicine, the very first study in humans. And basically, for the listeners, they took people with type 1 that did not that had the positive antibodies, the kind of get that when you get screened at TrialNet,
Hmm.
pediatric office, and these folks had the antibodies, So they were destined to get type 1 in a couple years or less.
Got
They
it.
went on this medication, which is only a 2-week infusion, one time, and then they let you go. And it turns out that you delayed the onset by 2 years on average.
Wow.
So some people got it faster, some people didn't get it at all.
Hmm.
And think about that. If you have a 7-year-old kid, a 10-year-old kid, and you said, I'm going to give you 2 more years before you come down with type 1.
Hmm.
And especially with all the developments that we've been talking about, that's like
Right.
going from multiple daily injections to a hybrid closed loop in 2 years. So, um, and then of course they're planning future studies, and other companies are working on other similar monoclonal antibodies. So I think the holy grail is to somehow genetically pick out people very early that they're going to be at risk for type 1, and then do some type of immune therapy early, or alter their DNA to prevent
Hmm.
them from developing in the first place. So, I don't think that's pie in the sky, but it is obviously down the road.
But it's exciting to think that it's in the realm of reality now, and that seems like it wasn't back when I was diagnosed 30 years ago. It just didn't seem like it was a discussion that you read about or heard about. And so the idea that there's a lot of hope baked into the research and the science that's taking place now makes me sleep better. I don't know about anybody else, but it definitely improves my baseline hope level.
You know what? Me too. So
Yeah.
I agree.
And that's kind of like a missing element, especially now that people are going full circle back to the pandemic stuff. There's a little bit of a shortage of feel good stuff. And so to take a little bit of time to focus on things that are going well, like we had Trang Lee on from Insulet here 2 weeks ago, or maybe it was 3 weeks ago, and she was talking about how people during the course of being in the isolation of the pandemic have seen better control of their blood sugars from the studies that from the data that they've seen. And I might be getting that a little tiny bit wrong, but it was more that as people are staying home, they're seeing improved blood sugar levels. That's the tiny bit of hope that you can pull out of a situation that's a little chaotic. So I like finding those bits and pieces here and there.
Yeah,
And
I
my
mean,
hope is the next time your camera will start. I have these hopes.
yeah, not to be Debbie Downer, but other people go the other way.
Hmm.
But it's certainly a good time to focus in on your diabetes. It's a
Hmm.
great time to check, if your basal rate is set correctly or your basal dose of insulin. It's a great way to really look at your insulin to carb ratio
Hmm.
to test it and your correction factor. So, I mean, I have a Peloton, and I had it before the COVID, and everyone's got to find a way to exercise. I think I'm
Hmm.
probably in better shape now than I was before. So, I think we all have to find our silver linings for sure.
Hmm. It makes getting through all of the stuff a lot easier, I think.
Yep, for
So
sure.
And so as we kind of roll, I don't see any questions coming in that we haven't already answered from the folks in the chat. But now is a good time for anybody if they have a question to drop that on in there. And Steve, we have about 8 minutes left. And again, I appreciate your time and you're willing to roll with the punches as we had some tech issues. I hope you didn't mind being my digital cardboard cutout during the course of this chat. Thanks for kind of working through this with us. But is there anything that you would your own? Okay. Is there anything you'd want to add in terms of telemedicine or devices or COVID or any of the kind of blanket of things that we've discussed already?
Um, well, I think the COVID we covered, but I'd like to just say that like you already said it, we have to acknowledge everyone's level of fear with this whole situation. I mean, it does affect primarily the elderly. Most people survive, but yet you see television and they show you like a 35-year-old nurse that was previously healthy who passes away from COVID. So that's scary. I do think we're going to get past it.
Hmm.
I think that everyone's working for a vaccine. Who knows if hydroxychloroquine or remdesivir really works well, but I'm thinking that even if before the vaccine, we have therapies to prevent people that need ICU care. And I think that we just have to stay positive and try to find the positive in this whole situation. And if you're not a positive person, I have 2 daughters. One's the glass half full, the other one is the glass half empty. So, we're all different.
Right.
Um, and I do think that we're going to get through it and just hang in there. In terms of the what's on the pipeline for for type 1. Well, first of all, I think it's important to say that so many people still do not wear a CGM or have access to one. There's a lot of different reasons.
Access, yeah.
Financially, insurance, maybe your caregiver doesn't believe in it, but I would like to urge everybody that getting a CGM is really the first step. And if you have access to a hybrid closed loop, I've never seen one of these systems put someone in worse shape than they were before going on it. It's saying that there is a learning curve. I do think that these dual hormonal pumps, not only with glucagon and insulin, but insulin and Similan, it being worked on. We can talk a little bit about the SGLT2 inhibitors and the GLP-1 receptor agonists. I'll talk about that during my talk at Friends for Life. And there are medications, obviously, other than insulin, that have been known to help people improve their time and range. They're not big differences, but for people that go on them, depending if there's a variable response, but for the most part, a lot of people love it. They're not FDA approved, so you got to use it safely. We have inhaled insulin now that's probably the single best way to prevent postprandial rise in blood sugar and avoid stacking sub-Q insulin and getting low later on. And that's been an excellent addition to so many of my patients. So I don't think enough people are taking advantage of that. So I think we're in such good shape for type 1s. And some of you old timers out there that are stubborn, if your A1C is good, your time and range is good, hey, more power to you. If it's not broken, don't fix it. But I would urge people who are struggling with their diabetes to look for better technology.
Well, in keeping with that, we do have a couple of questions that rolled in here. Are you good if I pop these into you?
Sure.
Okay, so one listener has written that they have two boys with type 1, ages 11 and 13, and they're tired of the skin issues they have from wearing devices. Any suggestions that could help? They're both wearing Dexcoms and Omnipods, but they're just tired of wearing it.
Gosh, well, I would say this, that that's I've worn that combo for a long time, and if you're tired of wearing devices, that's probably the best two to be on, because you don't have tubing. And I would just say this: the single most important thing is the Dexcom. And if you wanted to give them a break by getting them on to Jao and Tresiba, and using multiple daily injections, they're probably not going to like that either. But the only thing that they would have to wear would be a Dexcom, because I do think that's needed for safety and to prevent them from getting too high and too low. And you know what? It's not a bad idea to try it. Then after going on MDI for a while and becoming a pincushion, they might say, "Mom, give it back to me, please, please."
I was wondering if that's what you were going to say, because the few times I've taken pump vacations, I like it for about 6 hours, and then I realize that I don't like pricking myself, and I want to go back to the convenience of not having to do that. So sometimes the break shows me what I actually want.
Yeah, I would just let them know that, hey, we got to keep the Dexcom on, because that's part of the safety, and we'll take you off the pump and let's get a plan. And don't put it down. And plus, I shouldn't put down MDI. There's a lot of people out there that do extremely well. They use the pen, the smart pen, to help keep track of their doses, collects their CGM data. So as you know, Carrie, the majority of type 1s are on multiple daily injections, and as long as they're doing well, I don't care what you're on.
Absolutely. And I'm also looking at the part of her question that says that they're tired of the skin issues. And so I know on CWD we have a page that talks about skin irritations and ways to mitigate skin irritation, whether it's through a barrier tape or using some kind of topical application to help minimize skin irritation. But we do have a web page that I can direct you guys to after the chat is over. I'll make sure I send that out to you.
If they go to multiple daily injections, just make sure you get that flat basal. Talk to the doctor to make sure they know how to, the instructions, and then give their skin a break. There
it is. And then another question that we had come in, and they said it was great to listen to you with your expertise with T1D and as a clinician. They said they have a question for you as a patient. What do you prefer, a DIY system or a conventional system, or a 670G tandem with MCG, with CGM, I think is what they meant.
Yeah.
So what's your preference personally?
Okay. Well, Medtronic is just not an option. You know, the sensor's not as good. You have to prick your finger 2 to 4 times a day. It's hard to stay in auto mode. But I want to give Medtronic credit for bringing out the first one. They got their new edition, the 780G, coming out. So right now, I don't even think that's on the table for me. I did use the Omnipod with looping, and I really loved it. And I did that for a couple years. I love the way you light me up.
Sorry.
And then I've been on the Tandem Control IQ now for about 4 months, and they're both totally amazing. And there are pros and cons with each system. With the Omnipod system, I like the fact I can control with my phone. I didn't have to push like 14 beeps on my Tandem pump to get a bolus. And if I do have to do 1, 2, 3 one more time, oh my God, you know, and then you don't get it right the whole time, goes back, it times out. But I do like many things about the Tandem Control IQ. I don't have to, I'm not stuck to that 3-day, 80 hours that you have to change your, I like the fact I don't need to have my phone next to me for the system to work, as you do with the looping. I do like the hourly bolus. I'm having a lot of hard time with the Tandem with exercise, getting low during exercise. I don't think, and Tandem knows that too. They're going to do some software upgrades. I love the Tandem app where you can see the phone. So I would just say this, I'm kind of, I go back and forth. Did I like looping better? Did I like Tandem Control IQ better? And I have to say it's about 50-50. And I don't feel really strongly one way or the other. And I think if you're thinking about it, you should try them both if you could, if it's possible.
I liked listening to you run down kind of the pros and cons of all the different systems, because what that does is it puts a light bulb over my head that options are on the table. And so it's not just one system that works for everybody. There's lots of options that we can pick through to find the things that work for us. And so I think that's also what makes it a really good time to have diabetes, because we have different ways that we can choose to manage this. I think that's pretty
Carrie,
cool.
There's a lot more comparison, and Jeremy and I did a really nice piece, a video and a written piece on our website. And I think it comes down to personal choice. You know, like I said, I really like the Control IQ, and I missed some things about the looping with the Omnipod. You know, I was never a tubing person, but I'll be honest with you, I got used to the tubing. I didn't think I would, but I did.
Wasn't too much of a thing.
It's not that bad. I got the extra long tubing, so I put the catheter on the back of my arm where I used to put my Omnipod, and then it goes under my shirt. It's just walking around the house with no shirt on, and the tubing gets hooked on the doorknob as you.
Doorknobs are not your friend.
The doorknobs are not your friend.
No, but you get really good at like sort of angling around them as you walk through a house.
Yeah, just wear a.
I did have one question come in, and I know we're at time, so I'm going to try to get this last one in, and then we can send you the other questions if that's okay, and we can get some answers out to these folks. So we won't leave them unanswered, but they won't be answered during the course of this hour. The last one, because it is tied into COVID, we do have a question about inhaled insulin. And so as a clinician, are you concerned with the possible lung issues from inhaled insulin? And that can be both applied to inhaled insulin as a standalone thing, and then also in conjunction with concerns about COVID-19.
No, I'd say the answer is absolutely not. Now, if you get COVID, then I would stop it, because COVID affects the lungs. And so you don't want to add anything in there. You may not absorb the whole dose. Who knows? Maybe insulin in the lung helps, but no one's really going to test that. But I would just say in general, there's no reason not to use it. But if you get any type of upper respiratory infection, including COVID or the regular flu, just a good idea to stop it and have your plan B ready to go.
Got it. And also, and this is one of the 4th or 5th times that you've mentioned having a backup plan. I think it's good to kind of end on that, because as we're dealing with something that is unprecedented and uncertain times, I don't mean to roll my eyes, but they're just phrases used so often. It is the time to have your backup plan at the ready. And so to kind of close this out, what would you suggest that people have lined up in terms of making sure that they can navigate either a pump failure or needing an emergency prescription or something like that? Like, what should people have in their diabetes emergency kit for this particular time?
Yeah, I think that they should have over-the-counter medications for cough, congestion, and temperature. Tylenol is the best. Obviously you're going to have enough medication. And I think for people on, you should really know your sick day rules, which is, lots of testing, fluids, insulin, and don't forget carbohydrates. There's a good article on our website about what to do if you get COVID, because the last thing you want to do is get to the point where you're vomiting and you have to go to the emergency room where you're exposed to other people with COVID. So, we need to know those sick day rules anyway. So, and then, once again, if you're on Afrezza, or let's say your pump goes down, you definitely should have some basal insulin around, 2-JO or Tresiba or Lantus, and hopefully an insulin pen that you could give yourself injections without having to rely on the pump. And also, you should remember what your regimen is. A lot of people forget what their settings, they forget what their insulin to carb ratio is, and their correction factor. They rely on their pump, and you really need to know yourself. And if your hybrid system goes down, you better know what to do yourself. That's important too.
That's a good tip. I always take a picture with my phone of my pump settings, so that way I don't have to write it down and forget it, but it is in my phone if an emergency comes up.
But your phone may go dead.
Well, I mean, if it's my pump and my phone, I should just go outside and run around for a while because everything's going to craziness.
Have your daughter or your son take a chalk, put it on the front driveway.
And we'll just hope it doesn't rain.
Are your kids around? Could you bring it to the camera before you disconnect?
Absolutely not. I just heard my son sobbing in the kitchen. He's with my husband, so I'm going to leave well enough alone. And after we log off, I'm going to pretend to still be on the webinar so that I don't have to run right out there and see why everyone is crying. So sorry to be that mom, but I'm definitely going to be that mom. But Steve, thank you very, very much for spending this time with us this afternoon, for being flexible with weird technological gaffes, and also for being part of our Friends for Life virtual conference that's taking place in July. So we're lucky to have you as part of our team, and just thanks for logging in. I'll send you these unanswered questions this afternoon, but thank you so much, and we'll pretend that you are moving your mouth as you talk here.
You know what, it been my pleasure. I'm happy to answer more questions, and we'll see you folks at Friends for Life.
All right, thanks everybody for tuning in. We'll see you in 2 weeks.